Good afternoon to all. Firstly, I would like to thank the organizing committee for the invitation. It's an honor to be part of this summit. My name is Jeferson Zanon. I'm a nephrologist and I worked with palliative care about 7 years ago in Jales Cancer Hospital. This is a branch of Barretos Cancer Hospital. The title, I think, is the larger title of the whole conference today, but we perform a retrospective analysis of the role of antibiotic prophylaxis in placement and replacement of percutaneous nephrostomy catheters in patients with cancer and malignant retroviral obstruction. Um, this is our introduction, and the main indication for percutaneous nephrostomy is to clear urinary tract obstruction, but both in benign or in malignant diseases. But it can also be used to assess the other procedures such as nephrolectomy or to treat urinary fistulas, for example. The indication in cancer patients depends on the anatomical changes caused by disease in the urinary tract. Fortunately, with elevated rate of success. But like any procedure, it's not without complications, and infections are the most prevalent and the most feared among oncologists specifically. However, as shown in this table, in the literature, there are different definitions for nephrostomy catheter-related urinary tract infections, different names for urinary infection in different times. Oh, I'm sorry, this is the table. And different times of onset after procedure. Several studies, the definition, some studies have non-definition for urinary tract infection related to catheter. Some studies use the clinical and urine culture or even hemoculture. But the name is so rangy also in the literature, since urinary tract infection, renal abscesses, pyelonephritis, febrile episodes, and nephrostomy-related infection. Also, the time is very range. None is mentioned until 100 days before the procedure. And also there are few studies that relate that study catheter replacement. One way to prevent procedure-related urinary tract infection is the antibiotic prophylaxis. Interventional radiology guidelines are based on this study published in 1991, which evaluates sepsis after antibiotic prophylaxis or not in two larger groups. The difference, the authors didn't find difference in sepsis when the antibiotic prophylaxis was performed or not in a group with low-risk patients for developing sepsis without a statistical difference. But in patients with high risk for sepsis, that patients that were not performing antibiotic prophylaxis, the range of sepsis was about 50% with difference in statistical. They defined sepsis as chills and fever at the time, and the study was performed in both malignant and benign obstructions. They defined the risk, the high risk group for sepsis was elderly patients, diabetic patients, patients with bladder dysfunction, vesical indwelling catheter carriers, urinary tract previous manipulation, intestinal ureteric anastomosis, kidney stones, and bacteriuria. So based on these facts, we have decided to study what was happening in our institution regarding antibiotic prophylaxis and percutaneous nephrostomy. These were our objectives. We were trying to determine the rate of urinary tract infection associated with first placement of catheter percutaneous nephrostomy and catheter replacement. And we have to try to find some associated risk factors. We have conducted a longitudinal retrospective study analyzing data from patient reports in two hospitals of the same institution, Barretos Cancer Hospital and Jales Cancer Hospital. At Barretos, data were collected between August 2014 and December 2015, and both catheter first placement and replacement were performed with empirical antibiotic prophylaxis, according to standard protocol. At Jales, data were collected between July 2012 and December 2015. Catheter first placement was performed with empirical antibiotic prophylaxis, and catheter replacement was performed with targeted antibiotic prophylaxis, according to previous urine culture collected 7 days before the procedure. We have defined percutaneous nephrostomy-related urinary tract infection as any antibiotic treatment performed based on a clinical issues and positive urine culture 7 days before the procedure, not 30, not 60, not 100 days, but only 7 days before the procedure. For statistical analysis, the procedure was considered as a sample unit of, and these were the tests performed. We have submitted the study to our review board, and 234 procedures were performed by an interventional radiologist in 116 patients studied at the period. However, 54 procedures were excluded because they had treatment for urinary tract infection before catheter placement or replacement. Between them and 180 procedures, 48% went to catheter first replacement and 51% to catheter replacement. Just over half the replacement catheter procedure received targeted antibiotic prophylaxis. The main cancer responsible for urinary tract obstruction that required percutaneous nephrostomy was cervical cancer, followed by prostate cancer. 13% of these patients required percutaneous nephrostomy after cancer treatment. In other words, when they received only palliative care. And the urinary tract infection was the reason for early catheter replacement, less than 3 months, in 35% of the time. I think this is the main table of this study, because it shows that the rate of urinary tract infection after catheter replacement was higher, 11%, than the first placement, 1.2%, with statistical significance. For catheter first placement, the urinary tract infection rate was almost similar for those patients who received antibiotic prophylaxis or not. And for catheter replacement, the urinary tract infection rate was lower of those patients who received targeted antibiotic prophylaxis, but without statistical significance. We did not find risk factors for urinary infection after the procedure in our study, but I also to emphasize that 98% of the urine samples showed leukocyturia. Of these, 89% had no urinary tract infection. In other words, leukocyturia is not the same that urinary infection, especially with the presence of catheter. This retrospective study published in 2013 found previous urinary infections and neutropenia as risk factors for nephrostomy-related pyelonephritis. And the authors have concluded that antibiotic prophylaxis not prevent nephrostomy-related infection. This other retrospective study evaluated diabetes, previous urinary infection, neoplasms or obstruction, hypertension, and kidney transplant as risk factors for catheter-related urinary tract infection, and concluded a study specifically replacement catheter nephrostomy. They concluded that no antibiotic prophylaxis before percutaneous nephrostomy for low-risk patients, in other words, with no or one risk factor, does not increase infection rate. And just to knot our brains, this recently published Italian prospective study showed that there are no life-threatening infections after catheter replacement without antibiotic prophylaxis. What's the importance of this subject, especially for palliative care? Studying these implies using more rational antibiotics. This rational use of antibiotics avoid multi-drug resistant organisms that led us to difficult decisions the last day of patients regarding to treat or not to treat this kind of possible infections, as to say. And worst of all, a psychosocial burden. It's important because these patients often need contact precautions and isolation. And we are living nowadays with COVID-19. Well, to conclude, based on our results, maybe in the first placement, we don't need to perform antibiotic prophylaxis. And maybe for a replacement catheter, the antibiotic prophylaxis may protect some infections. But the question is not answered yet. And this is a wide field and a wild field to study, because this subject is very difficult to put in a role, especially for those who defend that antibiotic prophylaxis really prevents infections after the procedure, before the procedure, sorry. The figure above is Barreto Cancer Hospital, and the figure below is where I work at the town named Jales. So this is the Jales Cancer Hospital. Please forgive me for any mistakes on grammar. English is not my mother language, and I hope to have made myself understandable. Thank you so much.
Thank you. You're definitely very understandable.
Thank you.
Yeah. So are there any questions? I mean, I agree this is a very important topic in palliative care. There are a lot of patients with cancer that are going to need nephrostomies.
The indication of nephrostomies in palliative care is other objects of the study, because sometimes it's helpful, sometimes it is not, and deciding this is very difficult in the practice day by day. But infections is a concern, and maybe antibiotic prophylaxis that we are performing not help. We really don't know. We need more stuff to try to answer this question.